So, when you have a structured essay questions, you start specs so that it will help you to sort of, arrive at a tentative differential diagnosis or a diagnosis. And very often it's a differential diagnosis. So what is the most applicable differential diagnosis? You will have to work out from the information given, right? So if you really take this scenario, the fact that the child is 6 years old is important, so that you underline that. And admitted with fever for 4 days. So that is also important, that it's a febrile illness which had been there for past 4 days. And progressive deterioration of level of consciousness over last 24 hours. So once you said that, once you get that information, it obviously points towards a CNS infection. So because progressive deterioration of loss of consciousness, the commonest reason is CNS infection. However, that you have to be vigilant. Okay, are there any other clues for us to think of? Anything else other than a CNS infection for the child to lose consciousness, right? So let's have a look. So up to now, 4 days of fever, 6-year-old child, gradual deterioration of that is quite rapid, that you have to get that the level of deterioration of level of consciousness is over past 24 hours. He has been treated with co-amoxiclav by his GP. So that is also significant because he's been treated with antibiotic. There is no history of trauma. So that is significant, no trauma. So traumatic reasons for a deterioration of level of consciousness, such as intracranial hemorrhage, subdural, intracerebral or subarachnoid, all that is probably ruled out. He is the only child in the family, and his parents are school teachers. So implying that it is a well-cared child, and probably non-accidental injury, intracranial hemorrhage due to a non-accidental injury is very, very unlikely in such a social background. The child has not had any significant illnesses in the past and is average in his school performance. So there are inborn errors of metabolisms that you can have time to time deterioration of level of consciousness, child going into coma, then he recovers, then it happens again. So nothing like that, because in the past he had been apparently well child, and this is a developmentally normal child. There is no underlying neurological illness in this child, right? So then what other information is important in this scenario? On examination, he was febrile, so there is fever pointing still towards a possible infection, and he's drowsy and he's responding to verbal command. So we haven't really given adequate information for a Glasgow Coma Scale assessment. But under the immediate shorter forms of assessment of level of consciousness, we use AVPU. A is alert, V is for responding to verbal commands, and P is responding to pain, and U is unconscious. So generally it is been regarded that P is, if the patient is responding only to pain, that is equivalent to Glasgow Coma Scale of 8. But if he is responding to verbal commands, so that is probably like, if you tell him, okay, put your tongue out, open your eyes, that he is responding. So I would presume that his Glasgow Coma Scale is between 13 or 14, right? Very, very unlikely to be less than that. And there was no focal neurological signs, so which tells us which is also important to, like, it could be, when we say CNS infection, it could be an abscess, this could be a tumor. So they are a bit unlikely because there are no other lateralizing signs or focal neurological signs. So that is an important feature that you need to think of. Cardiovascular respiratory systems examinations were normal, and there was no hepatosplenomegaly. So following admission, he developed a left-sided focal conversion, which resolved within 33 to 4 minutes. Capillary blood sugar was 100 milligrams per deciliter, right? So at a subsequent stage, that there is a part which had been asked for the immediate management. So you will not get any marks for talking about management of a conversion here, right? If at all, during the conversion, I would look into these just one sentence, because they have already said it has now resolved. It has come and gone. So you don't have to talk about management of a conversion when it has already resolved, right? So, and CBS is 100 milligrams. So when you say the first question part of the question is list two important diagnoses you would consider. So when there is a child who is having a deterioration of level of consciousness, we have a background framework to work on it. Traumatic, non-traumatic. So this is unlikely to be traumatic. Non-traumatic could be infections, number one. Then rarely it could be metabolic. Metabolic could be either hyperglycemia, hypoglycemia, which has already been rolled out. If there had been a dehydration and the child is hyponatremic, that can lead to convulsions and drowsiness, but bit unlikely from the history. Then the toxins, poisoning, snake bites, are the other possibilities other than infections that you need to, and then obviously the malignancy, space occupying lesions. But out of the whole lot, the whole group, at the end of the history and examination, your CNS infections predominate. So what are the CNS infections which could be considered under these circumstances? So as number one, you may say because the child has had deterioration of level of consciousness, there is an element of encephalitis as well. So I would say either meningoencephalitis, partially treated bacterial meningitis. These are the two possibilities. When you talk about meningoencephalitis, it's usually viral that you are talking about. And then the GP had treated the whether this is a pyogenic or bacterial meningitis, which had been treated. So I would put meningoencephalitis, probably viral, and partially treated bacterial meningitis as the two important diagnoses you would consider under that. Anyone else has any other options for that particular component?
Yeah.
Sorry? Anyone else has written anything? Does everybody agree?
Madam, what about just meningitis? So encephalitis, sorry, not just encephalitis.
Just encephalitis, yeah, we would have given marks. Yes. Just encephalitis also would have got complete marks. Just meningitis also would have probably, if there was how many marks was allocated for that, you may be sort of deducted, because you have to, when you consider meningitis, you have to give some attention to the fact that it's the treated meningitis. So we would have given some marks. Say you get 10 marks for meningitis, we would have probably given 7 or 8 marks for just meningitis, and given 10 marks for the people who have written partially treated meningitis. You need to pick that up, because your investigations, your interpretation, all that is going to be different from a straightforward meningitis with a partially treated meningitis. So anything else? Anything else?
Madam, what about cerebral abscesses?
Cerebral abscess, I wouldn't probably would have got half a mark. If there was 10 marks allocated, you may have got 5 marks because you are worried about the focal conversion. I suppose you can't say wrong, but the fact that he had been, and the deterioration of level of consciousness was rapid, and he's having no focal neurological signs makes it a bit unlikely, but I suppose you are not wrong by putting it as a possible diagnosis, but definitely not the 1 or 2, it's probably the 3. So you would have the next component lists the investigations you would do with the expected findings. Can someone tell me what you all have written? Goodness gracious, there are a lot of Mr. Dots.
Madam, we do full blood count for look for the neutropenic leukocytosis or the elevation of WBC. If there's a bacterial meningitis, and if there's a viral encephalitis, look for the high lymphocyte count, and do the CRP.
But I don't know, I keep on disconnecting. So can someone tell me the list of investigations you think is important?
Madam, for the investigation full blood count, look for the neutropenic leukocytosis in the bacterial meningitis or the high lymphocyte count with high WBC in the viral encephalitis. And
Okay, so that's what you should do. You say full blood count, and then you make a sentence what you expect to find in the conditions that you have written above. So quite right. So number 1, start off with the simple investigation, full blood count, what you expect to find in a encephalitis, and what you expect to find in a bacterial meningitis. All right. Then
Madam, CRP should more high in the bacterial meningitis. Viral encephalitis also will be high, not like the bacterial one.
Very, very marginally. You would say maybe normal or marginally high, but in a bacterial meningitis, high or very high. All right. Anything else? Full blood count, CRP.
And madam, send blood cultures before the antibiotic given.
You have to do the blood cultures, but you have to make a comment, right? Although that you expect a positive culture in a bacterial meningitis, however, this patient has received oral antibiotics, therefore the culture may be negative. Make a statement that you are conscious of the fact that the child had received antibiotics already and the blood cultures may be negative, right? So that has to come there. If you have just said blood culture will deal the organisms, you may really not get the full marks because you have not given any thoughts to the a partially treated nature of this case. All right, carry on. So full blood count, CRP, blood culture, good. Anything else? The child is pretty ill now, no? So we can't just do only the full blood count, CRP, blood cultures. They are important in a diagnostic point of view. But then this patient needs to be monitored. He could have complications. So with that in mind, what else you will do as the baseline?
Another renal function test and liver function test can, because if the patient is
Yes.
having sepsis, can lead to impairments of the function.
Exactly. So when there is an encephalitis, although we presume that it's a viral encephalitis, viral meningoencephalitis, it still could be an encephalopathy. It could be a hepatic failure. We don't know. We are not 100% sure. As well as when a patient is very ill, they can go into organ failure. Therefore, and then renal profile, because whether it is meningitis or encephalitis, both can lead to inappropriate ADH during the acute stage. So if it develops, the patient can deteriorate further with the level of consciousness. So how do we know? By sort of, detecting a hyponatremia. Therefore, we need to have a renal profile, urea electrolytes, creatinine as a baseline. So yes, liver profile and renal profiling. All right. Anything else?
Can we consider lumbar puncture in this patient? Because the patient is already having features of
Yeah.
broken
So
CT
you can say lumbar puncture if the patient's level of consciousness. Now we are not very sure what the exact Glasgow coma scale is. Then you say lumbar puncture immediately if the Glasgow coma scale is 13 and above. However, if the GCS is 12 or less, then you do a interval lumbar puncture. So that all that statement should come in. A lumbar puncture can be done at this stage if the Glasgow coma scale is 13 and above. However, if the GCS is 12 or less, plan for an interval lumbar puncture. And then you say, what are the expected findings? So if it is a viral meningoencephalitis, there is not much of a sugar difference from so obviously random blood sugar also comes into the list of investigations. And you don't really expect to see dramatic fall of CSF sugar. However, if it is a partially treated meningitis, you will get, still you will see less than 50% of the blood sugar in the CSF sugar. CSF cellular count is what you need to emphasize. If it is a viral encephalitis, yes, there'll be more lymphocytes. In a partially treated meningitis, you may have some polymorphs. However, because it is partially treated, the lymphocytes may predominate. That you need to write that. If you say partially treated meningitis will have polymorphs, then you will not get marks because you are not conscious about the fact that the child has received antibiotics. What happens is the cell count reverses with a partially treated meningitis. So instead, you do have polymorphs, but unless it is a pure case without any antibiotics, you will have a predominant polymorphs. However, if it is partially treated, you still have polymorphs, but the lymphocytes may predominate. They may get reversed. So that you have to mention there. That is important. Any other investigation? So full blood count, CRP, liver profile, renal profile, they both could be normal. Random blood sugar for the CSF, it could be normal because CBS also had been normal. Then the lumbar puncture, stroke, interval lumbar puncture, depending on the Glasgow Coma scale and what you expect to find, there'll be a slightly increase in proteins in a bacterial meningitis, whether it is partially treated or untreated. But in a viral meningoencephalitis, you may not, or viral encephalitis, you may not see that any elevation in the proteins. Then the CSF culture and CSF for virology, CSF culture may be negative because even if it is a pathogenic meningitis, it has been treated partially. Therefore, CSF cultures may be negative. The same thing you wrote for the blood cultures has to be written under CSF culture. And CSF also could be tested for virology. And if the facilities are available, CSF PCR for herpes encephalitis, because it is important. This child has deterioration of level of consciousness, and viral encephalitis or viral meningoencephalitis is one of our main differential diagnoses. And the fact that because the child has had focal conversion, we have to very strongly think of herpes encephalitis as well. Therefore, under the investigation, I will also write blood and CSF for herpes PCR test if the facilities are available. Very often it's not readily available. However, for exact diagnosis that you need to demonstrate the positive PCR. All right. Enumerate the steps. So the place for neuroimaging in this patient is not immediate, but however, you can mention if there is any further deterioration in further deterioration in level of consciousness, I'll consider neuroimaging because also because the fact that he has had a focal conversion. So you have to mention something about a neuroimaging, and then the place for EEG. If the facilities are available for a portable EEG, or if the patient could be safely taken for the EEG room. And EEG is also valuable, particularly in viral encephalitis and particularly in herpes encephalitis, because herpes encephalitis is usually a focal encephalitis. So that is why there is some place in this patient for EEG and a neuroimaging as well, if it could be done. So enumerate the steps in the immediate management. So as I said before, don't go to talk in length about the focal conversion. So you can say since probably the patient has resolved with the conversion, and the GC Glasgow Coma scale is and under the, we don't know what the GCS is, under the AVPU that is responding only to pain. I will continue to monitor this patient, and under the monitoring that you need to write one after the other, right? So before that, I think it's best that you so you have a little framework before you start writing. What do I have to write? What are the themes under what themes? So under the management, you have to write about the drugs you use, acute management, long-term management, immediate resuscitation management, and acute management, and the long-term management. And in the immediate resuscitation, there are certain things that you need to consider. And then under the acute management, what are the drugs you use, and then the monitoring. So you have that framework in the back. So you could start off by saying this is a acutely ill patient, and therefore I would like to monitor him in the high dependency unit. And if there are no high HDU as the acute side of the ward, and this patient, after taking the investigations, he could have 2 wide bore cannulas. And the most important thing is treat the treatable for this patient. So therefore, since encephalitis and has had a focal convulsion, I would start with acyclovir, which is the treatable encephalitis, is herpes encephalitis, as well as partially treated bacterial meningitis is also a possibility. I would start on broad spectrum antibiotics such as cefotaxime or ceftriaxone as for a meningitis. So those are the two medication that you would start. We don't give dexamethasone for a viral encephalitis unless we suspect autoimmune encephalitis. Autoimmune encephalitis could very often have dystonic features. This patient did not have any dystonia or abnormal movements. So I don't think there is a place for steroids or dexamethasone in this patient. And if it is a PO, straightforward meningitis, also we do give dexamethasone. But this patient is not straightforward. He had been treated already with antibiotics and it's 4 days. Therefore, probably we will not use, and encephalitis is also on the cards. We will not use dexamethasone here. So you don't have to write that. If you write it, probably we will not deduct marks, but you will not get any additional marks. So those are the drugs. And then you can also talk about the monitoring. Under the monitoring, you can write it in bullet forms because now you have a limited space available to write. Therefore, you have to have your framework first. The students are generally very much used to just writing down all what you know, and then you need, ample space because you don't select what to write. You just want to write all what you know. That won't do, you have to be very smart and write in the given space what the amount of material that you are going to get marks for, rather than just writing off everything. So then under the monitoring, monitor the Glasgow Coma Scale hourly, and then the patient's other neurological examination at least 3 times a day. Monitor the temperature, monitor the vitals hourly. Patient has to be subjected to twice a day electrolyte, monitor the urine output. All these is important, right? Because that is what you are going to do with this patient. As well as now in encephalitis, other than now this patient, you can, at the very beginning when you talk about, I presume that the convulsion has resolved. However, I'll pay attention to the airway, breathing, and circulation. You may just include one statement so that you are conscious that the child you are attending to the vitals first. So that could have come at the very beginning, and then the treatable, then the monitoring. Then you can also, on another column, say neuroprotective measures. When there is a CNS infection and the child has lost consciousness, so we know either meningitis or encephalitis can damage the neurons and lead to permanent neurological sequelae. Therefore, we have to anyhow keep the intracranial pressure down to protect the rest of the neurons which are not damaged. So they are being called as a group neuroprotective measures. And they include nursing the patient with the head in the midline, 20 to 30 degrees elevated head end of the bed, then maintaining by any chance if the patient is being ventilated, maintain the partial pressure of carbon dioxide to the lowest part of the normal or low normal range, maintain the oxygenation well, nurse the patient in a dark and quiet room, so less noise, less light will help for the neuroprotection. So all those measures are called neuroprotective measures, which will help the child to not to have long-term neurological sequelae. So in spite of the treatment, what you have done, now the patient has gone in the AVPU scale and to 8 because he is now responding only to pain. So obviously there is increasing intracranial pressure in spite of what you have done all this time. And if there is intracranial pressure, increased intracranial pressure, that you need to reduce the increase in intracranial pressure. And the two drugs that you consider is either 3% sodium chloride, hypertonic sodium chloride, or else 20% mannitol. So we haven't asked for the dosages here. So if you had just written 3% sodium chloride to mannitol, that would have got the full marks. At this stage, the patient will also need, if they have asked for management, the patient will also need ventilation. When the Glasgow Coma Scale goes down to 8, that's an indication for elective ventilation. You don't wait for the patient to have any arrest, but you electively ventilate, and that will help you to keep the partial pressure of carbon dioxide also at low normal levels to reduce the ICP. All right. Any questions? When
I
is
mean,
the exam?
my exam is, madam, 22nd, writing papers.
Okay. This time you all couldn't do clinicals at the end of the appointment.
No, madam.
They didn't allow, or what happened?
No, madam, they plan to do like previous batches.
Oh, it will be. How many in the batch?
120, madam.
Oh, okay, okay. So all other subjects are also doing the same.
Yes, madam, except psychiatric, other subjects.
What do you prefer? Would have been better if you would have done it, no?
Yes, madam.
All right.
Madam, any place for Shigella encephalopathy in this patient, madam?
It's a very, very rare encounter. So in the absence of any blood and mucus diarrhea, you would have got a clue to that it's a Shigella encephalopathy by saying that it is following a diarrhea. So in the absence of such a clue, I would not bring a rare possibility when there are no clues. So probably you may get very small marks. You want to discuss this question also?
Madam, do
Yes.
we need to notify this kind of condition?
Encephalitis, meningitis, yes. Meningitis, you need to notify. Bacterial meningitis, yes. It's in the list of notifiable disease. All right. So you are called to attend the cesarean section of a mother whose antenatal scan has shown a lump in the lumbosacral region suggestive of a meningomyelocele. So diagnosis is obvious. It has been already given. And you are being tested of do you have adequate knowledge, what you need to do immediately, and what are the possibilities that this child could have as a result of meningomyelocele. So that is what is being tested here. So the baby weighed 3 kilograms and cried immediately after birth. So that means there is no immediate neonatal issues. So the baby will probably, knowing that there is a meningomyelocele, the attending doctor would have examined the spine and would have noticed this lump and taken the baby to the neonatal ICU. So what immediate step you would take as the attending house officer? It says that the baby cried immediately after birth. So you don't have to really go into details of resuscitation here. If we need, hello, හරි යට විනාඩි 10න් එනවා. So therefore, it's a bit irrational or waste of time if you're going to talk about resuscitating a baby. Since the baby has cried, I presume that his abgals are good and with a good weight, I would take the baby into the neonatal ICUs and examine the back. And if there is a meningomyelocele, which is suggested by the antenatal scan, I will nurse the baby in the prone position. So that is the most important thing, that you don't allow the lump to touch the rest of the cot. You nurse the baby in the prone position and you prevent dehydration by covering the lump with a sterile gauze, So that is, and then get the baby to breastfeed. However, during the breastfeed, also that you take care and advise the mother not to allow the lump to touch the rest of the body. You can continue breastfeeding, but taking adequate care of the lump, and it is being covered on sterile gauze. So that is all what is needed for the first part. You can also say, I'll check the blood sugars and the other thing, because they are going to ask the physical signs on the second part. So there's no point you writing in 3.1 as well, that leave what you are going to look out in the baby for the next part. You can just say that I'll ensure successful breastfeeding and just do a CBS of the baby. That kind of thing is okay, acceptable. So these 6 physical signs you will look for in this baby. So therefore, it is important, we all know that when there is a meningomyelocele, that you can have underlying neurological deficits of the lower limbs, and depending on which nerves are involved, which part of the pyramidal tract is involved, you can have upper motor neuron signs, lower motor neuron signs, a combination, bladder bowel involvement. So therefore, what I'm going to look in the patient. Number one is whether the lump is covered by the skin or it is exposed to the exterior. If it is exposed, that the risk of infection is high, and that may tell you that it is more a meningomyelocele than a meningocele. But if it is fully covered by the skin, it may be just a meningocele only without. But however, you cannot be 100% sure simply because it is covered that there is no neural tissue in the lump is not a guaranteed thing. But it generally more in favor of a meningomyelocele if it is open, and if it is covered, it is more in favor of a meningocele. So that's one thing you can write. Then the neurological signs of the lower limbs. If the patient has certain muscles which are affected with the upper motor neuron, they will be more hypertonic. Certain muscles which are affected with the peripheral nerve, they'll be weak. So there is an imbalance in the muscle power of the lower limbs, which will result in deformities. So deformities of the limb, and particularly congenital talipes deformity. Talipes equinovarus deformity is a classic deformity that we see in babies having meningomyelocele. So look out for that. Or if the lower limbs is entirely weak, if there is paralysis of the lower limb. How about the knee-jerk reflexes? What is the reflexes are like? So looking for talipes equinovarus deformity, looking for the tone of the baby's lower limb, looking for the power, whether there is weakness, looking for reflexes, all could be written. Then obviously the bladder and bowel involvement. If the S1 and S2 is involved, there'll be dribbling of urine, there's passage of urine all the time, and there'll be incontinence of feces as well. So, and if there is usually the S2 that supplies the external anal sphincter, and if you really look at the anus, when we do the neonatal check, we look at the anus of the baby, you can generally see the external anal orifice is constricted. However, in babies with meningobiosis, if S1, S2 is affected, the anus is gaping, which we call a patulous anus, So that's the term to use, that look at the anus and observe whether there is any patulous anus, look out for any incontinence of urine and feces, as well as, so that is generally for the lower limbs and the bladder and bowel. And we all know meningomyelocele are associated with hydrocephalus, particularly if it is a Chiari malformation. So therefore, you have to look at the head, measure the head circumference, and look out for any other signs of hydrocephalus like suture separations, open, wide fontanelles, setting sun sign, and look out for that as well. So you have more than 6 there, and any one of those would have carried. You've been 6. Each one would be carrying 5 marks. So list 3 long-term complications of this condition. Generally, most of the meningomyelocele do get repaired, and that's not the end of the story. They do have long-term issues. Number one is residual weakness. So they may not be able to walk. Even if they are able to walk, they may be weak. So that is residual weakness, and paraparesis is one of the complications. Then number 2, if the bladder incontinence is there, that could lead to a neuropathic bladder, and there'll be bladder trabeculation with retention and overflow as well, which will lead to the bladder trabeculation can lead to reflux, secondary reflux, and more susceptibility for urinary tract infections. So complications of the bladder or neurogenic bladder, which could also lead to reflux and even chronic kidney disease, right? So that is a very important aspect when you are managing repaired meningomyelocele in the long term, that you have to give due attention and proper management of bladder. So, which include intermittent catheterization, ambulatory catheter, prophylactic antibiotic to prevent infection, frequent monitoring of the renal functions, all that comes under the management of bladder complications. Then the third one, weakness, bladder, incontinence of feces could be again a long-term complication where you may have to be on Pampers in the long term. You may also write complications of the hydrocephalus and their sequelae as a possibility. So any one of those would be accepted, but weakness, paraparesis has to be mentioned, bladder complications has to be mentioned, neurogenic